cigarettes because of this. So yeah. Anyway, sorry, I'll stop talking. And
no, you're fine. Caroline, I just want to make sure I'm saying your last name correct. Is it Bermudez Joma?
That is correct.
Bermudez Joma. And
Most
Kelly
people just call me
Lydelman, I
Caroline
know.
Joma, but if you look me up on
Caroline Joma, you said?
yeah, no, but Bermuda's Joma would be correct because that's what I'm in the bar.
Got it. Mary Wozniak, Pastor
Yep.
Monica. We know Michaela. We can't say hello to Brittany because she's family, so we're not supposed to welcome her to the webinar, Heather Lynn.
All right.
Obadiah, shout out to you. Good to see you again. We all get to look at my pores. All right. Hey everyone, welcome back to the Flint Community Webinar, your community resource. We are packed with a bunch of really important information today. I'm really excited. Look at all of this expertise we have. We're talking about everything from measles and how you get measles and how we test and prevent for measles, and also what our measles rates look like in the community. We're going to be talking about kidney health and disease prevention. We're also going to talk a little bit about Medicaid enrollment and the impacts of cuts. We've got a bunch of expertise and we'll invite them and introduce them as we bring them up. But so great to have all this wonderful expertise here. Shout out to all of our wonderful community partners, and we'll get started by talking about measles. So I understand we've got like the health department, we've got Dr. Corsi, and we've got shout out to Obadiah Kirk, who's one of our second-year students in our Leadership for Medicine in the Underserved Certificate Program. Really great to bring you back, and we bring you back when you're really great at what you do. So last time you talked to us a little bit about bird flu and a bunch of stuff, and so we get to hear from you again. Shout out to Michaela Kersey and Joanne Herman from the health department. Talk to us about measles.
Alrighty, everybody. Hi, my name is Obadiah. For those of you who don't know me, I'm a second-year med student here at the College of Human Medicine. Today, I'm going to talk to you about measles, a not-so-friendly virus. We have a lot of information to cover. However, I have found a way to make this a little bit more simplistic for everybody. Okay? So, people are like, oh, this is a picture. You're like, okay, I know this is a picture of Obadiah. What is this? So essentially, this picture is telling a story of measles that we'll revisit at the end to tie in all the information that we've learned. So the story is that this dad, he has a weasel. The weasel is for our measles and such, and he's trying to rescue it from this barn fire, right? There's his daughter outside. She has a picture. She's looking at the measles, the weasel with measles, and she's on Instagram Live for some reason recording it. I think it's a pretty serious thing. In her right hand, she has a picture of a previous weasel that died in the fire. So in each component of this picture, something symbolizes everything. So we'll see at the end how this all kind of ties together, but just try to keep this image in your head. And for those of you who don't know, in medical school, this is how we learn a ton of information. So we use this for drugs, viruses. We use pictures to associate topics. So this is kind of like a free trial you are getting. Okay, it's like a 30-day subscription, cancel anytime, but there is no refund. All right, so with measles, it is a RNA virus. And the main thing from this slide that I want you all to direct your attention to is the top right, where you see it says family Paramyxoviridae and subfamily Paramyxoviridae, right? So with those elements, it's not super important for you all to know these specific details of the words, but in medicine, we use these categorizations in order to kind of direct our treatment and classify things so that we can better understand it. So you may hear this word Paramyxoviridae thrown around. It's unlikely, but just in case, we want to equip you all with this knowledge. And if you follow it down from the family to the subfamily, you see in this red box right here, it says the measles virus, and that's how it's classified. So measles is a single-strand RNA virus. There are all different types of viruses. We have single-stranded RNA, double-stranded RNA, single-stranded DNA, double-stranded DNA. Well, this is just the gist of the structure of what you all need to understand for measles. So transmission, this is like the really important part that you all really want to hone in on here, right? So how does measles spread? It spreads from coughing, sneezing, or talks with patient zero. So you're probably wondering, like, okay, well, but who is patient zero? So let's pretend we have a big family here, right? And we have a grandma, and we're all in the same house. And grandma is the first known case to have measles. And then she spreads it to the children, and then to the family, and then to the cousins. So grandma is our patient zero. She's our first known case of spreading the virus, in this case, to other people, right? And it's highly contagious. So the things to keep in mind is that measles can linger in the air for up to 2 hours. Even in the hospital, and there's a patient that has measles in the room, we're putting on like full gown, gloves, gear, everything, because it can spread rather quickly for sure. And it can be transmitted through like surfaces and body fluids. So we're not going to be hugging and kissing grandma for sure. That's a big no-no, okay? The clinical features that are associated with measles is that we're going to see a high fever. It's not super characteristic of measles, but there's a lot of things that you can get high fever with. But the three things that we like to keep an eye out for, these prodromal symptoms. So you are wondering, okay, what does prodromal mean? So prodromal is literally just kind of like a fancy word of a group of signs that maybe precede something else is coming for the most part, right? And those prodromal symptoms in this case are going to be a cough, a runny nose, and conjunctivitis. For those of you who maybe don't know, conjunctivitis is like when your eyes turn really red. And if you saw these three things, you would, especially in a child that's probably under 5, more than likely, you would probably suspect that, okay, they probably have a case of measles going on, right? So this prodromal, as I said earlier, follows a sequence of other things that may manifest. So 2 of those things that might manifest, one more likely, the other one less likely, is complex spots inside the mouth and a rash. So if you look here on the picture with the person's mouth open to their teeth, you see these little red spots inside the patient's mouth. And these spots aren't always present. In the case of measles, they can sometimes not be there. But what we do typically see is that rash, which is really important. So if you look at the young man's on the bottom of the slide, you can see the kind of bumps on his head. I wish I had a bigger picture to show you all on his back as well, but this kind of illustrates how measles can kind of manifest. So if you're seeing these prodromal symptoms, cough, runny nose, inflamed eyes, and they have a rash, there's probably a solid chance that this individual has a case of measles. Now, the complex spots, as I said earlier, may not always be there. Oftentimes when the rash appears, sometimes the complex spots are gone. So I wouldn't necessarily focus on using that as a reliable indicator, but it is something to keep in mind. So the complications of measles. Short term, the 4 things that we typically see are bacterial pneumonia for sure. Hospitalization is pretty frequent. Encephalitis, for those of you who don't know, encephalitis is when you have inflammation within the brain. And it can manifest in a number of different ways. Then you can have death about 1 to 3 per 1,000. So the important thing to keep in mind for the short term before we address the long term is that typically children under 5 or individuals who have a compromised or deficient immune system are most susceptible to contracting a case of measles. So that can be anybody who's on chemotherapy. It could be individuals who are pregnant. It could be elderly. All these people have weakened immunity or compromised immunity to some degree. So as a result, this herd immunity, which I'll address a little bit later, is also important for us to keep in mind when we think about prevention and vaccinations. Now, the long-term implications of measles is something called subacute sclerosing panencephalitis. So that's a very long word. We're just going to call it SSPE to keep it simple for you all. So instead of like explaining it in terms of the clinical standpoint, I'm going to paint you all a story. All right. So let's say we have a 5-year-old. 5-year-old comes into his pediatrician, and the pediatrician says, okay, you have a case of measles. They treat the 5-year-old. They provide supportive care because there is no true cure for measles. We just provide maybe like fever reducers, fluids, things of that nature. And then the 5-year-old recovers, able to go home, right? So now the 5-year-old, let's fast forward 10 years, is 15 years old. And for some reason, unbeknownst to anyone, the child is having seizures, they're having headaches, personality changes, they're confused, and there's nothing else going on. The child's not sick or anything, it just kind of happened randomly, right? So the parents bring the child back to the doctor, that same doctor, and the doctor looks back at the chart and saw that 10 years ago, that child had a case of measles. So what this physician is more than likely thinking is that this may be a case of SSPE. So SSPE is a long-term complication that can happen, doesn't mean it always will, but it can happen with individuals who do experience a case of measles. So you may see it somewhere between 7 to 10 years post, according to the CDC. All these stats you can find on the CDC, or you may even find it longer. So your attending or your physician would find that this is something to keep in mind 10 years, 7 years post if they have a child coming in that previously had a case of measles and is presenting with those things of seizures, maybe personality changes, mood changes, memory loss, things of that nature, okay? So back to the treatment and prevention. If you direct your attention to the right, we see the measles, mumps, rubella vaccine. So in any case and scenario, the best treatment is always prevention. So when it comes to measles specifically, getting this MMR vaccine can help increase that herd immunity, meaning that if we have 10 people that are maybe susceptible to getting measles and 8 of them get it, the chances of the other 2 getting it is less likely for sure. So this is why we would like to emphasize, as usual with our seminars, the importance of treatment and prevention. In this case, it's the MMR vaccine. All right, so let's get back to the picture. So now you've learned all the information. Now let's tie all this together. So the dad's trying to rescue the weasel with measles. So our anchor is this weasel. The weasel has measles. And as the dad's running out of the barn, he hits his head, right? And his brain is now feeling it, right? So this is going to represent the encephalitis, one of the common complications that you can sometimes see in individuals who have measles. In addition, you can see that the dad's eyes are really red. We talked about that conjunctivitis, how they can be inflamed. If you look at the nose, you can see that the nose is runny. It's that runny nose that we mentioned. And we have the cough, as well as these little spots of soot that's on the dad's mouth. Those are meant to represent the Koplik spots. So we have all 3 things of that prodromal sequence of measles. Now, as we move down to the dad's arms, we can see it's kind of red. So this is going to represent the rash that you would see in measles as well. We notice as well, he's a farmer. So of course he's wearing suspenders, but his suspenders are going to represent SSPE, right? So suspenders, SSPE, the long-term complication that you can sometimes see in measles. Now, if we move over to the right portion of the image, we see that we have mittens, like a pair of mittens. So paramyxo is what we would call that. That's how we kind of classify the virus again. The daughter, again, this time she's on Facebook Live streaming the whole event for the whole community. All of Flint is watching this, ladies and gentlemen. So she's filming this thing and she's doing it live. So one of the vaccines that we utilize in this specific case scenario is a live attenuated vaccine, and it is it's called MMR. So if you look to the right of the picture, you can see the M memory of. It has the uppercase M, and the larger R. That represents the MMR vaccine. And it's a live attenuated, meaning that we give you a weakened version of the actual virus. We put it inside your body learns to defend itself from that virus. So in the event that the true virus, maybe out in the community, was ever to engage with you, your body has already built up a sufficient enough defense to kind of fight it off. All right. So that's the main picture. So now we're to the summary. So what did we learn? We learned that measles is an RNA virus for sure. It can be spread through the air. It is highly contagious. So please keep that in mind when you're hugging and touching your loved ones who maybe have it. It has the prodromal symptoms. We talked about the cough, coryza, all those things, the runny nose. And does have a rash as well. And vaccination is one of the key elements, ladies and gentlemen. So with that, that is all that we have for the breakdown. I hope you all enjoy the rest of the presentation. I have to get to class, but if you have any questions, feel free to ask the panelists. I'm sure they'll be able to help you out, and y'all take it easy.
Thank you so much, Obadiah. That was wonderful. I really appreciate the illustrations. And yes, don't be late to class. We appreciate the expertise. And as usual, when you do a good job, we'll be asking you to come back. So thank you so much for being the expert in the room today. And we look forward to hearing more from you.
Sure.
Awesome. One of the questions we get, and I'm gonna shout out the people that we have as panelists again to help us think about some of this. And if we could bring, I don't know if we still have Dr. Taylor forward. Always good to have a pediatrician as a part of these conversations. But we got Joanne Herman from the health department, Dr. Corsi from the health department, and Dr. G representing the community questions. I saw one really great question that I'll put up for anyone and that I get in my office sometimes, which is Obadiah mentioned the MMR vaccine. And he mentioned, right, that that's going to be a live attenuated vaccine for measles, but the other M and R, as we know, stand for mumps and rubella. And I wondered if someone would talk about why we combine those. Why do we give it as one shot is sort of the question. And I'll know in my office that the thing that I'll say is we're giving these vaccines because it's a live attenuated virus. We have to wait a little bit for babies' immune systems to tolerate it. So we typically are waiting a bit to give it. But when we do give it, we're also trying to give as few shots as possible so that babies have as few pokes as possible. So that's one reason. And some of it is the efficacy of being able to get babies as, you know, immunity as efficiently and effectively as we can. And so being able to combine the ones that we're able to does help us from that perspective.
Yeah, I would just piggyback on that. I mean, every time we have an opportunity to vaccinate a child, we're trying to capitalize on it. And, you know, there's been a big push and movement to get more and more vaccines where we have combinations so that way our babies can be really well protected, but we don't have to give them as many pokes. So, I mean, we talk about MMR vaccine, but now we have the MMRV, so that has varicella included as well. So there's definitely a large push to try to combine them as long as it's safe. And when we study the vaccines and we know that it's safe and it provides good, robust immune response in those combinations, it helps let everyone along the way, right? It helps parents feel more comfortable about giving less shots to their kids, but it helps us as physicians to know that our kids are getting the best protection as possible.
Thank you. All right. Any other comments about the combination?
About how they're all together. Sorry, I feel
Yeah.
like Joanne Herman and Dr. Corsney are probably some of the experts at this too. And I feel like some of this is sometimes something that I talk about. I feel like being boring and like giving a history lesson. But it's the fact that all three of these viruses, as he was just pointing out, are very similar in the way that they work, and that they're all these RNA viruses in the same family. And so when the vaccine was being manufactured and like came, you know, developed and all these things, however many years ago, they knew that probably they were going to be able to hit multiple aspects of that same virus because they're really similar. So only by changing just a little bit of each of them, they could actually cover all three of these viruses because they're all in the same family. So I feel like that's a big thing that I talk about, that you're getting like a 3-for-1, but it's only they just gently changed it, just kind of like the way that we change the flu shot every year, just to kind of adjust to those sorts of things. And that's a very similar thing. That's why the MMR vaccine was manufactured and developed the way that it was, just because the viruses are so similar. And so you get a little bit of the you know, the kind of the baseline just from that. And it's kind of boring on the history and how they came up with it. But it makes a lot more sense once you know that part, I think.
Yeah. Thank you for that, Dr. Taylor. How long after, and I think we get this question with a lot of vaccines. I get it in my office all the time. How long after getting the vaccine are you covered?
It's approximately 2 weeks.
So after about 2 weeks, then you sort of have the safety and effectiveness and response needed from the vaccine. Awesome questions. I'm checking to see. Oh, yep, this is great in the chat. The MMR vaccine is given together to reduce the number of shots, ensure timely protection, and maintain safety and effectiveness. Absolutely. This is a good question for the health department to think a little bit about. How can people check the status of their vaccines? So how can people know if they're up to date on their MMR?
So we use our MICR system and all of our providers, and there's also a way is our community at large can look at their records to see what their vaccination status is. as adults. And for myself, my childhood vaccines are not in the MICR system. It may be in a medical record, or you might have record of it, but if we're poor historians, we may not, as adults, necessarily know what our status is. But it's widely available for our children and our young adults, that they should be able to see everything that's been given in the state of Michigan in the MICR system. So if I had some of my shots in Florida or Ohio or somewhere else, and I'm looking in the MICR system, unless it was put in as historical data, I may not see my full profile.
And Dr. G in the chat kind of references a way that you can test to see if you did, right? So that would be you could get titer levels to make sure that you showed that you had the necessary immunity from MMR.
Yes, I was also just going to add on briefly to that, the MICR, which is our immunizations record for the state, it is required for children's immunizations to go into that. So, some of our older people in our community who got vaccines before MICR existed or before this immunization record existed, you might have to do some tracking down of your records like Joanne mentioned, or you might need to opt into thinking about those MMR titers like Dr. G mentioned, but for our children and the people that are getting vaccinated now, those are all required to go into that system. Mm-hmm. And you can always reach out to the health department. We can help you navigate that. And often your pediatricians can often help you get your records as well.
Thank you for that. What advice, so if let's say you have a patient or a parent coming in and they're a little unsure about whether to move forward with the MMR vaccine, what advice do you have for parents, people who are, unsure about moving forward with getting vaccinated?
I'm happy to talk about this because I do it a lot. So I think a lot of times the first thing that I like to talk about is what the concern is, and that it's really valid to be nervous about this. You should be, it shows me that as a parent and a caregiver, you care deeply about your children and about their health, and you want to do what's best. And I'm here to help you kind of navigate that, especially when there's a lot of science and a lot of things behind it that you don't necessarily understand. And it's my job to make sure that you understand that in a way that makes you feel comfortable one way or another. So I think I just want to put it out there right now that the MMR has never been associated with autism, and it has been heavily debunked. I know probably most people are like, yeah, but again, we know that that's not always the case at this point, and it has been heavily studied, and there has been no link to autism or any other neurodevelopmental disorder in any of the schedules that are out there. And so I think that's a big thing. And so the other things I talk about, the usual concerns that I have with the MMR vaccines when it comes to complications or things like that. So it's super safe. There are some complications that you might get from it. The biggest thing that happens is that you get a fever, and that's it. And the arm is a little bit sore after. Sometimes you can even get a little rash around it, and those are the most common. And again, most common being like that's 1 to 2% of the millions of people who get MMR. There can be more extreme complications of it, such as a febrile seizure that comes from, aka a seizure that you get because you had a fever after it. And then there can be really, really like 1 in a billion kind of things for these vaccines. And again, anytime that anyone ever has a concern, I'm worried that my kid is, going to have a complication from this vaccine. I talk about the numbers between the risk of that encephalitis that he was just talking about is so much higher than the risk of that one. Pretty sure for one of the more severe like allergic reactions is 1 in like 1.5 million. I'm sorry, I don't know the number off the top of my head, but I know it's more than 1 in 1 million, which is significantly higher than the risk of getting the encephalitis from measles.
Dr. Taylor, I want you to like underscore that point because literally my student and I were just having this conversation about how we talk about this. And I think it's really important for us to understand that risks are a thing, right? We understand that there are risks to the vaccine. And I want us to be really clear because I think one of the things we do sometimes is we talk about all of the great things about vaccines, and vaccines are really great in their prevention ability. They do come with risks, and they're risks that we acknowledge. When we're talking about why vaccines are important, we're talking about the difference between those risks and the risk of other things that we also know, right? And I just want you to talk, like, say that again, just so people are really aware that, like, there are risks, but the risks of sort of encephalitis, the risk of all these other things associated with the things we try to prevent are bigger risks that we're a little more afraid of.
I feel like that's a huge emphasis that I put on is that this is validated and we use this because the risk of the vaccine is so much lower than the risk of the disease. Everything that we do in medicine has a risk to it. Every time I give you an antibiotic, every time that you get an x-ray, every time that we do a procedure, there's always a risk with it. But that's a big thing that we do before we approve or decide that this is a standard of care, is that the risk of the procedure or whatever we're doing outweighs the risk. The risk of the procedure outweighs the risk of the disease and not doing it. And so vaccines are like one of the safest of all of the things that we do. And so I always really try and emphasize that. And sometimes I think looking at the numbers specifically for the risks of the complications compared to the risk of what happens if you get the disease is really, really helpful. And I think with measles, that's a huge one because it is not just a cold. It is not just a rash. It is so much more than it. I did my training in New York during the measles outbreak there and saw someone with encephalitis, and it was horrible. And so, I always bring that back that this was something that I have seen before, but I have never seen a complication from a vaccine, from a severe reaction to the MMR vaccine. But I have seen in the very few cases of measles that I've had in a patient with encephalitis. And so, when I think about that, sometimes I think that helps kind of bring everything into context when I'm talking to a family. So
I love that you said that because for me, it's not rare if I've seen it. Right? Like if I've seen it, I no longer decide that it's no longer defined as rare for me. And I will agree with you. I have seen complications of vaccine preventable illnesses way more than I've ever seen a complication of any vaccine, including like erythema at the arm site. Like I've seen way more complications of influenza that was not there where someone wasn't vaccinated or of vaccine preventable illnesses than I've ever seen of vaccine reactions. And I think we should just think about that in terms of the context of what is rare and what is not, and what is risky and what is not. All right, thank you so much. I want to just check. I'm looking to see if there's any more questions that we didn't answer in the chat. I know Joanne Herman was going to talk to us a little bit about what we're seeing in Genesee in terms of rates.
Sure. Well, last week I checked our rate for measles completion rate, and we were at 81.2%. And that means, and I looked at it again today, and our rate declined slightly. It's now we're at 80.1%. And if you think about it, you think, well, that's pretty good. 80% of our community is covered. But if we look at the Texas area that has the outbreak right now, we were on par with them, and now we're a little bit worse than that area. So Genesee County is very vulnerable. We are uncovered, and we have a lot of work to do to improve our rates. If you think about community immunity or herd immunity, that's at 95%. So we really have much to do. In the chat, you'll see that we at the Genesee County Health Department created a measles toolkit. And in that toolkit, it really gives our physicians the tools, the nurse practitioners, PAs, clinicians throughout our community to really look at what is available, what we can do to, if they suspect measles, what they can do for education materials, and what they can do for testing. So please look at that in the chat. That is a very handy tool. Feel free to share that with the community. We've done general outreach to our providers. We did this in the fall, and as there's been more interest in talking about measles, it's a good time for us to push that out again. And I know, Dr. Corsi, you also have been very instrumental helping push that out to people throughout our community as well. So I just wanted to give that as a reference to all of you on the call, that resource for us.
And
Yeah,
Joanne,
thank you.
I'm sorry, go ahead, Dr. Corsi.
Oh, I was just going to say that, this is something that we're, like Joanne mentioned, we are watching the situation that's happening in West Texas and New Mexico, and we're just really following closely because we understand our vulnerability. So we're trying really hard to get the message out to people in our community members, our providers, and let them know all of the information that they can. So that way, hopefully we don't end up in a situation like what's happening in Texas.
So in that toolkit, we actually, like, we'll pick Dr. Taylor's practice. We've actually showed the team how to identify which of their clients that are coming in or haven't came in 6 months to a year, where they can find those people and do some education and outreach, do some recall, in spite, with the vulnerability, to let them know that they are eligible or that they are overdue, either for their second shot, or maybe they haven't had at all their first shot. So we're really trying to give our team the tools. We've worked with our POs, our PHOs as well, so that we can really make sure people have the information to know that they're behind on that schedule.
Ooh, question in the chat. Where can I get the vaccine?
Come to visit us at the Genesee County Health Department. You can, if the child is a little bit older, they can go to their local pharmacy, and their primary care medical home is a great spot. Always, I'd put that number one, your primary care medical home or your pediatrician. A lot of family physicians also carry that vaccine in their office as well.
I was going to say, and if you're an adult and you need your booster, or you're not sure if you need it, so if you were born between like 1957, 1965, that's like a really, really big thing. So you can get yours at almost all of the primary care offices. And I know that you can go to the health department as well in case you don't carry it, because sometimes, because it is a pediatric vaccine, and an adult only provider won't have it, but all family, if your doc is a family practice, or your provider is a family practice doc, they should have that as well. And I also always want to preface that if you accidentally get too many, it would never hurt you. I've actually gotten 6 of them accidentally because of being not having the right records and different things like that. I was just talking to the chief medical examiner, Natasha Bagdasarian, and she has 4. So I was proud that I had beaten her on my amount of MMR that I had gotten her.
I feel like I need to
again,
get one. Yeah, like
Yeah.
I feel like I need more just to be in the same like space with you.
Yeah, no, it's okay. It's just because I was did a couple trips abroad, and so that everybody they line up and you give you the MMR. So I promise I'm MMR'd up. So so I always want to make sure that, it's just like with almost all vaccines, even if you've gotten one before and you're not sure, you can always get another one. Especially, I know this is something that's come up recently with people thinking about traveling and being older, and different individuals. You're always good to get another dose of it. But if you don't get the dose, you're not going to get protected. So.
That's kind of exactly what we're seeing in terms of questions in the chat. So you kind of answered the question about what should I do if I need to get the vaccine, or can I get another one? What if someone has been exposed to measles? Can we talk a little bit about what people should do if they think they've had a measles exposure?
Yeah, absolutely. So if someone has been exposed to measles, so in this situation, most likely what's going to happen is somebody from the health department is going to be reaching out to you. So you'll have close contact with somebody from my team. And what we'll do is we'll talk to you and we'll try to ascertain what your vaccination status is. So if you know you've been vaccinated, if we can see your immunization records, typically we just have you monitor for signs and symptoms. And if you were to start developing symptoms, we would check in with you, and then we would reassess at that time and talk about testing, etc. But if you are somebody who has not been vaccinated and you've been exposed, then that is definitely like number one recommendation, is that you would get vaccinated as soon as possible. There's potential for some other things such as an immunoglobulin, depending on how far out, but the number one goal would be as soon as possible, we would get you vaccinated, because for measles specifically, it can actually help prevent illness if we get you vaccinated early enough.
Thank you. Okay, I want to make sure we have a little bit of time to talk about kidney prevention and Medicaid, but there are a couple more questions, and then I want to give you an opportunity to drive home any last points you want to make sure that we get to that are super important. We've got this question that is okay, I got vaccines as a child. Do they no longer work if I was born before 1957?
So if you were born before 1957, you likely have immunity because for measles, mumps, and rubella, because at that time there was so much in the community that you're most likely exposed to it. There sometimes, and this is a question that's come up, is that sometimes I'm like, if we're not sure about it, if you weren't positive,
Get the
'cause
vaccine.
it was when you were 2 or 3, just get the vaccine.
Right.
Just get the vaccine if you're not worried about it. We really started rolling out the MMR vaccine around 1965. So if you were born then or around that time, then you most likely have received a dose of the MMR. If you're not sure, just get another one. So that's a big thing, is that I'm always just like, just get another one. And it's not, the vaccine has gotten better over this time, but the basic, tenets of it and the efficacy has not it wasn't so bad at that point that you wouldn't have held on to that immunity. So I always want to emphasize that. But again, if you are not sure that you got it, and just get another one. There is a way to do titers for it. And I think Latrice had brought this up as well, that you can do that. It's not perfect. There is a possibility that you may have the titers, but don't have actually a robust immune response to it, or vice versa. So a lot of the times I'm always just like, let's not do 2 pokes. Let's just do 1 poke,
right?
give you the MMR. And then rather than doing that, I've also had people get the bill for the
For the
titers.
titers.
Yeah, so I'm always trying not to do that as well. And I think that speaks, not that our healthcare billing system is perfect by any means, but it speaks to the fact that there are less expensive and more kind of evidence-based ways to go about doing this. And so that's just getting the MMR vaccine. So.
And I want to just echo that's the CDC's recommendation, is that we don't need to go about doing titers right now. Just get it if you're not sure. So
Yeah. All right. Any last comments for all of the experts in the room? Go ahead, Joanne.
There was an open question about vitamin A, and I know that's hit the national news quite a bit, or there's been a lot of talk about vitamin A. And if you go back to the very beginning of our presentation, that measles, the best protection to prevent the measles is to get the vaccination. And getting vitamin A or having vitamin A supplement can't prevent the measles. In some, developing countries where there's poor health, having high nutritional status is important, and that may be a factor for vitamin A, where there's deficiency. But in our United States, there's less than 0.3% is there a vitamin A deficiency. So I know that was a question, but vitamin A does not prevent the measles. So
I think it's vitamin A.
I
and
always
cod
want to
liver
emphasize
oil.
that there's real complications from hypervitaminaosis. It is a real thing, and it does not take that much to overdo it. So please, if you are insistent on taking vitamin A, please talk to your provider about it, because it is very easy to overdose on it. I do not want to see anyone in my office with something like that, because we know what happened with COVID and people going out and doing things, trying to keep themselves healthy. Like, talk to somebody about it, because it can be really easy for you to overdo it. And again, it doesn't prevent it. It doesn't work. So.
Dr. Taylor, I think that gets at your idea again of risk, right? Like, everything that we try has risk, and we need to be understanding if that risk is more significant than the other opportunity. In the case with vaccines, we're saying you get the prevention, it's lower risk than the risk of vitamin A toxicity, it's lower risk than sort of any of the other things. And so that's how we make decisions about, say, suggesting people get the vaccine. Is there a lot, hold on, I can't see. Is there a lot of people taking vitamin A? Should we start educating the community on this more? Well, it seems like Dr. Taylor has just brought herself another visit to talk to us a little bit more about vitamin A, which she tends to do. She comes with wonderful expertise that always has us asking more. So I'm going to give Dr. Corsi and Dr. G the last opportunity for comments.
Just basically that myth busting about the vitamin A, because it's circulating now that if you take it, also it prevents it or treats it. And cod liver oil, so always check with your primary care provider. And like Joanne and Dr. Cussy stated, taking the vaccination is the best way to prevent the measles. That's all I have.
Thanks, Dr.
yeah, I agree. Just I think the other thing I want to reiterate though is that, if you have your 2 doses of your MMR, you're very well protected. And if you have the vaccine, and even if you were to be exposed and you were to get sick, you are so much less likely to have a complication from that. So the vaccines aren't only effective in protecting against illness if you are exposed, but they also help reduce that risk of something bad happening as well. So that's why we're just really supportive of everyone in our community getting vaccinated.
That makes total sense. Thank you so much. All right, we're going to pivot a little bit to talking about kidneys. So we have got Terry Walters and Mary Wozniak. Thank you so much. March is Kidney Month. So talk to us a little bit about kidney. How do we keep our kidneys healthy?
Yeah, it's very timely talk. Thank you so much for the invitation. I'm going to go ahead and share our slides here. Just want to make sure you can see that okay. So we are both with the National Kidney Foundation Michigan. We're a nonprofit in Michigan, and our focus is on preventing kidney disease and improving the lives of those living with it. We want to talk to you about chronic kidney disease, or what we call CKD. It's a big public health issue. We're going to talk through some of the risk factors, benefits around early detection, and a brief overview about managing kidney disease. And then Terry's going to share some NKFM programs that could be beneficial to your patients and community. So kidney disease, chronic kidney disease means the progressive loss of kidney function over time, so at least a 3-month period or longer, leading to other health problems. So heart attack, stroke, those are much higher, much more likely for people who do have CKD. It can ultimately lead to kidney failure and death. Typically, there's no symptoms. We say that the kidneys don't cough. So especially at those earlier stages, the best way of finding chronic kidney disease and preventing its progression is to test for it in people who are at high risk. And there is no cure for chronic kidney disease, but there are many ways to slow that progression down, including many medications, healthy eating, and lifestyle changes. At the later stages of kidney disease, you might notice swelling in feet or ankles, foamy urine, that can be a sign of kidney problems, blood in the urine, fatigue, or loss of appetite. And then end-stage renal disease is what we call kidney failure. This is when the kidneys can no longer function on their own, and it does require dialysis or a transplant to survive. But really, our focus is on trying to catch it at those earlier stages, and again, reduce the need for anyone ever ending up on dialysis. Low recognition of chronic kidney disease is a public health problem because it's associated with so much morbidity and impaired quality of life and shorter life expectancy, as well as excess healthcare costs. Around 1 in 7 Americans do have chronic kidney disease, although up to 90% of them don't know that they have it. That's because we're not always testing as regularly for that. So that's something we really like to raise awareness among the medical community about. It's the 9th leading cause of death, but again, it contributes so much significantly to cardiovascular disease, which is the leading cause of death in the United States. So the top 2 causes of chronic kidney disease and kidney failure are diabetes and high blood pressure. So really a lot of our focus is on this sort of earlier stages of encouraging healthy lifestyles and preventing diabetes, or best managing high blood pressure to begin with. But you may be familiar with the term cardiovascular kidney metabolic syndrome. This is a complex disorder made up of obesity, type 2 diabetes, kidney disease, and ultimately cardiovascular disease. These 4 are so interconnected, so it's important to understand the risk factors, and that one can kind of lead to the next. People often have more than one of these conditions at the same time. And CKM has become an increasingly common condition that's characterized by the intersection of these conditions, according to the American Heart Association. And up to 1 in 3 Americans may be already at risk of a stage 1 or later of this condition. Now we're going to talk about the risk factors for CKD. As I mentioned, diabetes and hypertension, these account for about 65% of cases of kidney failure. But other things that can damage the kidneys are using NSAIDs frequently. So many of us will have ibuprofen, or naproxen, something like that in our medicine cabinet. Chronic use of those can damage the kidneys, as can obesity and smoking, both increase your risk of kidney damage over time. Some non-modifiable risk factors are family history of kidney failure, being of older age, and certain races and ethnicities do experience higher rates of CKD compared to white adults. So people who are African American, Hispanic, and American Indian do have higher rates of CKD. And then people who have experienced an acute kidney injury, this can happen during a critical illness or hospitalization. Those folks should be monitored for continued progression of kidney disease. I think it's important to mention some of the environmental drivers, although I will say that there's still a lot of research that's needed to really understand the full impact of these environmental factors on your kidneys. But it is known that heavy metals can contribute to kidney damage. So lead, which of course is a concern and has been a concern in the Genesee area, cadmium, arsenic, and mercury. Small particulate matter is also associated with higher rates of kidney disease, as are PFAS and certain pesticides and herbicides. We do have references at the end of this that we'll be emailing out, so feel free to check that out. There are some studies in there on environmental factors, but I'm not going to go into a ton of depth just because of the time. Do want to mention a campaign that our organization has been really promoting throughout the state of Michigan, and the idea is to raise awareness about the risks of kidney disease. So 1 in 3 adults, up to 33% of people in Michigan, are at risk of developing kidney disease. This is a kidney risk quiz. It just takes about a minute. It's about 5 questions long, that we're encouraging folks to take. So if you haven't had the chance to take it, or if you'd like to take it on behalf of a loved one, please feel free to access the quiz here. And we would love for you to also just generally share this out with your community and your patients. The campaign has been adapted to different communities as well. Specifically for the African American community, Hispanic, Spanish speaking, as well as adapted to in Michigan specifically, we've worked with the Native community to develop a campaign for their communities, as well as a campaign in Arabic to reach the Middle Eastern and North African population. I do want to point out specifically in Genesee County, this is a look kind of county by county within Michigan of the prevalence. When we say prevalence, in this case, this is diagnosed CKD. So I do just want to clarify that, the prevalence is likely higher. It's just that we don't always diagnose it early. So within the state of Michigan, about 8.2% of Medicaid beneficiaries have a diagnosis of chronic kidney disease compared to Genesee County, which is a bit higher. And you can kind of see the areas in darker orange are those that have the highest rates. So kind of that middle of the mitten, the thumb area, as well as Southeast Michigan have the highest rates. People with diabetes are encouraged to get tested for chronic kidney disease every year using 2 tests, the eGFR and the UACR. There is a quality measure associated with this called the HEDIS KED measure. So this heat map is looking at what percentage of people on Medicaid who have diabetes have been tested in the previous year. So within the state of Michigan, we're testing about 1/4 of people with diabetes. In Genesee County, it was slightly lower at 24.5%. So it kind of gives you a sense of the areas where there's still more work to be done, certainly in terms of getting those screening rates up. Early recognition of chronic kidney disease offers an opportunity to enhance kidney protective care. It allows us to treat it early, make those lifestyle changes to slow down progression, and also to make an appropriate referral to nephrology. And nephrology is really important in terms of getting that kidney education about treatment modalities before a person reaches end-stage kidney disease so they can make an informed decision. And also some of those modalities require some time, a few months, to get like an access place for dialysis. So the guidelines that we follow are NKF, KDOQI, as well as KDIGO, which is more of an international guideline. But they do recommend assessing all patients for chronic kidney disease risk factors and then testing those who are at risk. So in particular, those with diabetes and hypertension. CKD is diagnosed using these 2 lab tests. The eGFR provides insight into your overall kidney function. This is included in common blood tests like the BMP and the CMP. And then the albumin to creatinine ratio is a urine test that looks at the extent of kidney damage. It can often find kidney damage prior to that eGFR actually declining.
And Mary,
And it is,
if I was just like give some context to like why we study these two, right? So if you think about the function of your kidneys, there really are to filter, right? And so that GFR really just tells us if your kidneys are filtering appropriately. And then the other test tells us if you're filtering the right things, right? So is there protein going into your urine that shouldn't be going? Are there other things into your urine that shouldn't be going? And so just to give you a little bit of context for why we get these tests, obviously not Mary, because Mary's the expert here, but to give the rest
no,
of you
perfect. I
a
appreciate
little
that.
bit of context to why
Yeah.
we do some of this testing. And I'm so glad you're talking about these. Thank you so much.
Thank you. Appreciate that. I will also point out that ACR is not, the nomenclature has not necessarily been adopted across all the labs in Michigan. So you may hear this referred to as like a microalbumin to creatinine ratio. There are different names for it. So if you're not sure, do check with your laboratory as to which are the correct tests to be ordering for that particular one. Once you test for CKD, it's really important for a provider to establish whether there's chronicity, so if there's at least 3 months of an abnormality, and then to classify the CKD based on both its cause as well as the GFR level and the albuminuria. So this so-called heat map can be useful in particular to determine the risk level of that person going on to either experience kidney failure or a cardiovascular event. So you'll see the green areas, this person is at very low risk of progressing to kidney failure. And then as you go closer to the dark red, your progression gets more and more severe, more and more risky. So at the point of having, at the top, you'll notice the albuminuria categories. So A1 is considered normal if it's below 30 milligrams per gram. Moderately increased and then severely increased would be over 300 milligrams per gram. And really, that's the point at which you would likely refer to nephrology to determine the cause. And there's many medications that can actually reduce that level of albuminuria. And then on the left-hand side, it shows your GFR level. So this is really what we consider the staging of kidney disease. Once you fall below 60, that is considered stage 3A, but it is possible to have kidney disease higher than, if your GFR is higher, if there are other indications of kidney disease like albuminuria or blood in the urine or other things like that. So we definitely encourage the use of the heat map in line with those guidelines. In terms of managing chronic kidney disease, these are really the main factors that to focus on. Lifestyle modifications would include limiting dietary sodium, encouraging physical activity, smoking cessation, and weight loss if needed. Whereas the patient safety, that's going to look at, avoiding medications that are toxic to the kidneys, so such as NSAIDs, certain antibiotics, and others. And then preventing chronic kidney disease, really you're looking at those two factors again, controlling the hypertension, controlling your blood sugar levels if you have diabetes. So medications such as ACEs or an ARB for blood pressure control, as well as an SGLT2 inhibitor. Those are kind of considered the frontline medications for this condition. There are many others as well. I would refer you back to those guidelines that I mentioned. There's a reference at the end. And encouraging vaccination, certainly for influenza, pneumonia, COVID. And the reason for that is that people with CKD have a much higher likelihood of hospitalization or complications from those conditions. And then certainly managing cardiovascular risk, because we know that's the #1 way that people with CKD actually die is not from kidney failure. So that includes the use of statins, as well as SGLT2Is can help manage cardiovascular risk. And then finally, monitoring and treating for complications that can include metabolic acidosis, bone and mineral disorders, and anemia are common complications.
That's so important. Mary, I was just thinking like some of these things I'd love to even bring you back on to explore more of like how do we get to some of these complications and what what people need to consider, right? Like even as you're talking about NSAIDs and ibuprofen and those things that are risks for people, thinking about that. I wondered if you'd go to your last slide that had the references. I saw there were a couple of references that I wanted to make sure people.
Sure. Yeah, please.
Okay, these are amazing. Oh wait, no, go back one slide. This, okay.
Okay.
Yeah, because I wanted people to make sure they got an opportunity to learn where they could learn more about CKD management before we handed it off to our Medicaid people. But
Great.
the chronic disease self-management programs and the medications to consider in CKD management, I'd love if you'd come back and talk to people about what kind of medications we should be thinking about and what other things we should be thinking about in chronic kidney disease.
Okay. I love that. Thank you for the opportunity.
Awesome.
Yeah. Yeah. And
Awesome.
let us know if there's any questions. Please feel free to reach out to myself or Terry if you'd like to talk any more offline.
Oh,
as
you
well.
already bought yourself another visit to the webinar. We appreciate you. All right.
thanks.
So we have talked about how to prevent measles. We've talked about prevention in chronic kidney disease. And now we're going to talk a little bit about how we pay for some of the things that we might need access to and some of the safety net services that exist for people. And I get into trouble every once in a while by leaving people only a few minutes to talk about really important topics. So Kelly, you might have bought yourself another visit too. But I would love for you to tell us a little bit about what we should be thinking about right now.
All right, just real quick. I'm the director of the Center for Civil Justice. I'm joined by Carolyn, who is going to go through our quick PowerPoint. I just wanted to explain that the Center for Civil Justice, located in Flint, advocates for people living in poverty, and our priorities are health equity. Medicaid insures 2.6 million Michiganders of our population. Medicaid's the largest insurer for our most vulnerable populations. Today, we're defending massive cuts to Medicaid that have been voted on by both the House and Senate in their budget resolutions. Go ahead, Caroline.
Thank you. Thank you for the opportunity to speak about Medicaid, what it is, who is covered, how it's funded, what types of cuts the federal government is proposing, and what you should do now to try to protect Medicaid and our Michigan community. Because together we can make a difference. So let's begin. What is Medicaid? Medicaid is a public health insurance program that covers 83 million low-income children, seniors, disabled people in the United States. It's financed by both the state and the federal government without a preset limit. States have the opportunity to administer this within the broad rules, federal rules, and that's why each state has different parts for Medicaid of what you could get. So each state is different. Next slide. I also wanted to tell you is that Medicaid covers over 17 million people, and 1 in 5 people age 50 to 64 is covered. It covers more than 6 out of 10 persons who are nursing home. It's the lifeline of more than half of 14 million children with special needs. And it supports schools, the school nurses, the psychologists, the social workers. So Medicaid covers a wide range of areas. Now, when we look at the budget, we can see that for the federal budget, in looking at 2024, the receipts are less than what is sent out from the federal government. And Medicaid and CHIP is over $564 billion for the United States as to what they cover. Next slide. So when we look at Michigan's Medicaid budget, we know that over 2.6 million people are covered in Michigan, and over 26% are for all of Michigan, which is covered. We want to look at just what's happening for Flint or Genesee County, which is in the 8th congressional district. There's over 766 million people in that congressional district. And Children under 19, over 40% are covered in this congressional district, and under 65, over 27% are covered. So what's at stake here? Next slide. Well, when we look at what the federal government provides, gives to Michigan to cover for the Medicaid, we can see that they're planning and proposing cuts. What kind of cuts? Block grants are one of them, which means that the federal government would just give a block of money to Michigan and say, you figure it out how you're going to pay for the rest. Or they say per capita, we're going to give it per head, and then you figure out, Michigan, how you're going to cover the rest. The problem with that is that the money that was being given to cover Medicaid, it will not be sufficient if you're just going to give us a block grant or per capita. And then Michigan has to start making decisions as to what they will cover or what they won't. It impacts us all. Another problem that we see is that they are thinking about proposing work requirements. When we look at work requirements, we know that work requirements don't work. Everyone who is working, who can work, is working. And it just has more red tape in terms of making more additional steps for the MDHHS workers to try to figure out who can work and who can't work. But when we looked at some of the statistics I just gave, it's covering children and disabled people and nursing home people, and people, who are elderly. So work requirements is just another way to say you're not going to get Medicaid. So why is this all important? Because our community will suffer and our state will suffer if we don't have sufficient funding for Medicaid. This brings us to a call to action. What can you do? You can call this number, put in your zip code, and it will get you to your congressional person. You can leave a message as to why you think Medicaid is important and why these cuts shouldn't happen to Michigan or to any state, so that we all have the safety net of health insurance that we so desperately need. I know we're on the 1 o'clock point, so I will see if Kelly has anything else to say. These are some talking points that you could give your congressional person, and it's important because health insurance should be given to the most vulnerable, and we need to help protect it for them. Thank you.
Thank you so much. Thank you. And thank you, Kelly. Thank you, Caroline, for that important information. I want to give Pastor Monica the last word. We've talked about a lot of important things today, and she's going to be frustrated with me because I did not give her the appropriate amount of time, but you have a few seconds, minutes to talk to us.
Oh, thank you so much. I put a few statistics in the chat. Michigan United is hoping to support a grassroots local effort on the county level, along with the Center for Civil Justice and many healthcare providers and healthcare agencies, social service agencies. In Genesee County, real quick, 28% of all of our population is on Medicaid.
Yeah.
That's everywhere. All municipalities considered. That's 112,000 residents. About 56% of all births, which includes your prenatal care, the birth, and postpartum, are covered by Medicaid. 93% of the mental health services provided at Genesee Health System is Medicaid reimbursed.
Yep.
Cuts, reductions to Medicaid are going to upend our entire healthcare delivery system. It is that big. And it's not even just the impacts to the county's budget itself, because health department programs, other social service programs are supported by federal dollars. It is those dollars plus our entire system of healthcare, nursing homes, you name it, and the senior care and all the things that Caroline touched on. So this is a very big deal. We're helping to lead that effort. Our goal is to work with the county and county commissioners. We need a plan for Genesee County. Like, how do we mitigate this if cuts or reductions are made? What will that mean? And so we're trying to start that conversation. We had a presentation to the Board of Commissioners this week that was well received. So if anyone would like to be a part of that project and the conversation and really just connecting around the advocacy efforts that are needed, right, to support the county and to support our infrastructure that provides this care to folks. And I think a biggest part is that your patients need to know that this could happen. We are not seeing a lot of just general public even realize, for example, people don't realize they're on Medicaid. They think I'm with Molina or I'm with this company, right? They don't realize this means you, this means them. And so whatever advocacy you can do in your offices, in working with folks, what we can do in the public arena, it helps. And call the Congress. That matters too.
Thank you, Pastor Monica. Thank you for all of you who tuned in and all of our experts and all of our wonderful panelists. Super appreciate you.